Hi, I'm Aaron Logan from the University of California, San Francisco, and I'm pleased to join you today to talk briefly about how transplant options have changed for patients with acute lymphoblastic leukemia. One of the principal ways that transplant options have changed is the increased use of alternative donors, such as haploidentical donors and cord blood donors. We have now data from the Center for International Blood Marrow Transplant Research, the CIBMTR, showing a pretty dramatic increase in the use of haploidentical donors across all acute leukemias and other diagnoses such as MDS. But in particular in ALL, there's been a rapid rise in the use of haploidentical donors. And this now enables transplant for a significant portion of the ALL population that previously wouldn't have been able to find a donor. There are also pretty excellent data suggesting that use of cord blood can be favorable for outcomes with patients who have acute lymphoblastic leukemia. So this is something that can be considered as well. And I think I would say that the benefit of all this is we now can find a donor for essentially every adult acute lymphoblastic leukemia patient who needs a transplant. We're, I think, getting better at identifying patients who might benefit from transplants, those who have standard risk, who achieve MRD negative remissions, probably can avoid a transplant, whereas those who have high-risk genetic lesions and those who do not achieve MRD negativity with standard multi-agent chemotherapy should go to transplant, but typically with some therapy to achieve MRD negativity. So that's the second realm within which transplants have changed for ALL, which is the awareness that going to transplant MRD negative is extremely important. And we now have the option of giving lintuzumab as a bridge to transplant in patients who are MRD positive after multi-agent chemotherapy. And this maneuver of giving blinatumomab as a bridge to allogeneic transplant has proven to be very successful with excellent long-term disease-free survival. And so it is now a standardized recommendation, even in the NCCN guidelines, to really consider blinatumomab as a bridge to transplant in patients who are MRD positive. For patients who have relapsed refractory disease, it is certainly desirable to achieve a high quality remission. There are many options available now to do so, including blinatumomab with or without other agents. Inotuzumab is also available. And CAR T cells are increasingly becoming available through clinical trials and through anticipated FDA approvals in patients of higher ages than currently approved with, for instance, Tisagen Leclucel. So I think the CAR T cell story is continuing to evolve, and we are hopefully learning as a field how to employ CAR T cells as an option for patients with refractory acute lymphoblastic leukemia to achieve high quality remissions, MRD negative remissions. And the data that are now emerging, I think, sum up to say that indeed there probably is a benefit to going to an allogeneic transplant after a single antigen directed CAR T cell. And that is my practice, and I think the practice of a lot of other people taking care of adults with relapsed refractory acute lymphoblastic leukemia is to take them to an allogeneic transplant after CAR T cells. And the data are firming up to support that as probably the best route for patients in this particular scenario. And then the last consideration for how transplantation is changing for ALL is, what do we do after the transplant? What can we do to mitigate the risk of relapse? What can we do to improve disease-free outcomes and overall survival after allogeneic transplant? So one of the things that we can do is better understand the quality of remission and the maintenance of an MRD negative remission. We can employ MRD assays such as the FDA-approved clonoSEQ assay and NGS assay. We can also use bona fide MRD flow cytometry to assess disease burden after transplant. And I think in the current world, we need to make decisions based on the presence of any detectable disease after transplant. And there are a number of things that we can do, such as early immune suppression taper, donor lymphocyte infusions in patients who are off immune suppression and have not achieved full donor chimerism. And there are studies ongoing to look at, should we be doing other things, such as giving maintenance therapy? There are some early studies looking at lintuzumab as maintenance therapy, either as a prophylaxis against relapse for all patients. Another way of considering this would be preemptive therapy for patients who have evidence of MRD progression after transplant. We're still awaiting an evidence base for deciding how exactly to employ that most efficiently and cost efficaciously. But those data are emerging and developing. So hopefully we'll understand better whether patients with acute lymphoblastic leukemia should get some kind of maintenance therapy after transplant. But in the meantime, I think that early immune suppression withdrawal and other manipulations of the immune system, such as donor lymphocyte infusion, can be a way of trying to deal with MRD after transplant and hopefully improve disease-free survival, preventing florid relapse, and ultimately, I hope, leading to better overall survival for patients afflicted with this disease. So those are the domains in which I think that we're currently making advances. I hope that we continue to find other agents that can be used both to achieve high quality remissions prior to transplant. I'd love it if we find agents that can obviate the need for transplant. We're not there yet. Transplant does remain the best curative therapy for patients with high risk or previously relapsed or refractory acute lymphoblastic leukemia. But this is a very rapidly evolving field, and there will be more to come, hopefully, in the near future. And I'll look forward to talking to you about that as those things emerge. Thank you.